Happy Thursday and welcome to the next edition of Ask Behavioral Health. I am Dr. Haley Quinn. I'm a psychologist here at Swedish, and I am joined by...
Hi, I'm Brittany Neidhart, and I'm a licensed clinical social worker, also with Swedish.
Well, thank you both for joining us today to help bust some mental health myths. I want to encourage anyone that is tuning in, you're welcome to ask any questions about myths that are on your mind. And if you just give us a like, we would appreciate that as well. We're going to start it out pretty light. There's a very common mental health myth that you only use 10% of your brain. Would you address that for us?
Yes, that is quite popular. We were just talking before we went live about just things in pop culture that sometimes bring this to the forefront. So we were talking about how this myth seems to be perpetuated by a movie, perhaps, that came out that kind of talked about this concept of, you're only using parts of your brain and there's all this potential that's untapped. But actually, our brains are a very complex organ, and we are constantly using all different parts of our brain in different combinations and in different ways. And so the organ itself is very efficient, and we really use all of our brain, just maybe not all at the same time, but it's very complex and integrated in the way all that comes together.
Yeah, no, that's one of my favorites. There are like movies and TV shows. I think it's Limitless, where this person took a pill and suddenly, was a super genius and using 100% of his brain. So it is interesting because our brain is constantly going and working together. And when you're breathing, you're using part of your brain. As I'm gesturing, I'm using a part of my, so everything's working together. It's not to say that we can't strengthen connection in the brain and learn new things, but we're at full capacity most of the time.
I would say so.
Well, thank you for busting that one. We're going to take it to we got this in our inbox, and it's somebody who is dealing with depression and struggling with it being their fault. Would you just break them down why depression isn't your fault?
Yeah, I'd love to take that one. I'm a very strong advocate for breaking down stigma surrounding mental health and depression, anxiety, schizophrenia, bipolar disorder. Any mental health diagnosis, it is absolutely not someone's fault that this comes about. We know that there's, a lot of times a genetic component to something like depression or any mental health disorder, and environment plays a big role. Mm-hmm. But at the end of the day, it is not your fault. It is a responsibility to do something about it, I firmly believe. But when it comes to the actual illness of depression, that's not something we choose, ever. So if we could choose, we would choose absolutely to not experience depression.
Right. Yeah, and in our series that we do with our lives and our podcast, we talk a lot about the guilt and shame surrounding mental illness. Mm-hmm. And like Brittany said, I think we often might suggest to patients, if you could feel better, you probably would have done that a long time ago. So this isn't a choice. This isn't a decision folks are making, and oftentimes the things that they are struggling with are really, really difficult, hard things that, of course, you would feel distress in some way, or of course you would feel heartbreak or heartache, and just really be in a bad place. And so, I certainly hope that myth is busted for folks, and that that this is not a choice to feel that way.
Okay, thank you for that. We actually got our first question from the audience. I want to thank Teresa for participating, and her question is there a single group that's more likely to experience a mental health condition versus another?
Sure. That's a great question. I think different age groups might experience different types of mental health conditions. Mm-hmm. One thing that kind of popped to the forefront of my mind when that question was asked is I think about older folks and the elderly, and one of the mental health issues that comes up in that environment oftentimes is loneliness and isolation. And so I think depending on the age group, we might be talking about different types of mental health issues that might affect certain groups more than others. And certainly things like depression and anxiety can occur across the lifespan. And oftentimes it starts as young as childhood for a lot of folks, and it's coming up before age 14. So I think the statistic, Brittany, you can correct me or kind of fill in here, but over the course of the lifespan, you know, the majority of adults will experience some kind of a mental health issue. So it's certainly prevalent.
Yeah, no, absolutely. The number that is thrown around recently is 1 in 4. So 1 in 4 people will experience symptoms that will basically lead to a diagnosis. So they're meeting the criteria for a mental health diagnosis. And age certainly is a factor for, you know, what illness you might experience. Also, you know, there are factors around stressors. I just was talking about sort of genetic factors. If you have family members, immediate family members with mental health disorder, anxiety, depression, we feel there's, you know, this predisposition potentially to develop those. But it may never happen if a particular stressor doesn't manifest. So people who are under really difficult stressors, socioeconomic stressors, trauma, you know, in a big way trauma, and particularly kids who go through adverse childhood events, you know, these are people who tend to be more at risk.
Okay, thank you for that. We have another question. This one is from Sean. He would like you both to address the idea that certain mental health conditions are preventable or if they are not.
Good. That's a great question. I think, you know, especially with more attention on to mental health in society, I think a lot of people kind of then ask themselves, you know, well, what can I do to maybe prevent this from happening either in my child or for myself or in family members? Like, is there a way to prevent these kinds of illnesses from occurring, and or things that might, you know, make it more likely that they could occur? And I think Brittany touched on that a little bit. So with mental health issues, there's genetic components and there's also the environment. And so for most conditions, those things kind of go together. It's not one or the other. It's kind of a combination and a complex combination of those two factors together. And so, you know, while we can't always do anything about the genetic piece, I think that we can have an effect on the environment. So at the individual level, it can be offering support with mental wellness. So not necessarily waiting until there's a big problem, but learning coping skills, learning how to manage feelings, learning the skills for how to get help. I think that's being taught more in schools, and kids are getting that education. And then I think as a broader society too, just like making sure that we're addressing the kinds of issues that kind of lead people down the road to have mental health issues. So making sure that people are getting the support they need from a societal perspective as well.
Absolutely, yeah. I mean, that's right on. I mean, we are talking more about this, which is, I think, a key component, because recognizing maybe signs and symptoms of something like depression or anxiety, or even things like schizophrenia or bipolar disorder, you know, some of the more severe and persistent mental illnesses that we can see, you know, it is, once we recognize those things, the sooner we can treat them, the more, usually, the more hopeful the prognosis. So particularly, we're starting to see studies with schizophrenia and noticing when maybe a teenager or someone in their early 20s is having signs of that first psychosis that sort of you know, starts to show like something like schizophrenia, and intervention, like wraparound intervention at that age during that time, can actually very much improve someone's outcome down the line. So I think that's a very, very valuable thing for us to talk about and to recognize.
Sure. I have to add this one anecdote I heard recently in an article, and it was talking about how in mental health we often, there's like this saying like, well, put the oxygen mask on. It's like an airplane. Put the oxygen mask on the other person or yourself before you help the other person, which I totally can get on board with that. But then in this anecdote I was reading about, it was saying, well, maybe we should also be stopping and asking why the plane is crashing, you know? Yeah. So kind of just, I think that's important to bring in, like, sometimes these things are the product of, you know, an environment that has been created. And so, you know, whether it be like a failing school or just, you know, a poor home environment or whatever it is, that those kinds of things are being addressed, or, you know, workers who are being overstressed. So I think those are things that we need to also kind of look at as well.
Awesome. So I do have another question from the audience. This one is from Sarah. She wants to, she asks, how do you address your manager when they tell you to just leave your problems at home as if you can just turn it off?
Sure, you want to start that one?
Sure, absolutely. This speaks to the broader issue of education around mental illness, people being informed, and understanding the role that they play, I think, in helping someone. Again, addressing the stigma issue, the myth that if you have an issue, you have depression, you have anxiety, that you can just will it away or put it on a shelf. Certainly in that sort of situation, it sounds like this manager, has never had depression, has never had anxiety, and might assume, oh, you've got problems like everyone else. Just, leave them at home and then come to work and then you can deal with them when you get home. And when we're talking depression or anxiety, when we're meeting that clinical criteria, it doesn't turn off. Again, if we could, we would. So in that situation, depending on how receptive a manager is, having a conversation around that, as honest as you can be and say, this isn't just I have problems going on in my life. This is I have clinical depression. I have clinical anxiety. I am trying to get help and I'm doing my best. And these are the accommodations that, would help me get there maybe faster.
Yeah, and I guess when I hear that too, I think about like this particular manager. I mean, I think we all have moments in our lives where we have, a particular life issue or stressor. You find out that like someone hit your car right outside the office, or like these things happen. And so I guess I'd be wondering for that manager, like, well, what do you do when a crisis hits or when life happens? And I think that kind of attitude of like, well, you just stuff it down and you move about your day doesn't sound very healthy to me. And I like to think that some of this is changing, that, the culture is changing in workplaces around like understanding that employees are humans and that they work better when they're supported from like a holistic perspective. But, I think that some of that is still out there. And I think if you're in that environment, maybe thinking about like, if this is a really good workplace environment, if you feel like, you could look elsewhere or maybe talk with HR, kind of figure out ways to better your workplace, I think like that would probably be a good thing to be thinking about.
And then I think we can circle back with this person to provide some resources that kind of show that anxiety and depression isn't something that can be turned off, so they have that when they meet with their supervisor. But moving on, we have another question from the audience. This one is from Mary Beth. How do you recommend broaching the conversation with a family member who you think might need support? Maybe not quite a myth, but I think it's a good question.
Sure, yeah. Well, I think a good place to start is usually to just maybe get them in an environment where they're comfortable, maybe kind of go for a walk or something non-threatening that feels comfortable for them. Maybe it's not the best thing to do to like call them in the middle of their workday or while they're commuting or something like that and spring it on them. But maybe find a time where you can really connect with them in a way that feels non-threatening. And then I think it's always good to open the conversation to ask them how they're feeling and what's been on their mind, and just start from there, because it can potentially feel a little bit like an attack, or it might just feel a little aggressive to somebody if they already are having their own like guilt or shame around this. And so I think if you can just open the door to that conversation by asking them how they are, and then maybe, the next step would be to say like, I noticed that you seem down, or I noticed I haven't heard from you in a while, or whatever it is that you're seeing might be a way to open the door to that conversation. What do you think?
Yep, I would agree with all of that. I think, I think face-to-face is important, definitely. Going for a walk is, I think, a really good way to do things, just because, you're kind of moving, the person's able to kind of look around if they're not comfortable. So depending on what the person, finds relaxing, or, easing into it versus, I've noticed you've been feeling this way, and, So, but then, following that up with, this is how I normally interact with you, and things are different, and I'm concerned. It's okay to tell someone, I am concerned about you, and having it come from a place of non-judgment and understanding.
Sure, yeah. And then depending on like what you hear, maybe not saying like, well, I think you should go to therapy, or I think you should, break up with your boyfriend, that would solve the problem. But instead, maybe just offering support, like, well, how can I help you? How can I make, this burden less for you, is also something to be thinking about.
Absolutely.
So we have another one via private message. This is from Ben. He says, my mother tells me that sugar will cause me to be hyperactive. Is this true?
Oh, yes, I love this one. So I would say I have to take this.
Yes.
So I hear this one almost daily. So I work in pediatrics, and I hear a lot of parents say, well, that day they just got so much sugar and they were out of control, running around or whatnot. And so there's actually a lot of research behind this. And sugar actually does not cause hyperactivity. That is a myth that we feel pretty good about. Like, we can put this one to rest forever. Sugar, in fact, has nothing to do with hyperactive behavior. The research that they've done around that is using like placebo effect and things like that to show that it's more about either the idea that you've given somebody sugar and now you're seeing behaviors and you're linking it back to that, or the activities surrounding the sugar are like amping up the kids.
Sure.
So, when do you have sugar? Well, at the fair, at a birthday party, at an event, a family gathering, at a summer barbecue. So probably their behavior is going to be a little bit out of the ordinary in those environments. So really, again, sugar doesn't cause hyperactivity. Let's put that one to bed.
Awesome. Well, thank you for that. We're going to go back to a question that is in regards to mood changes and bipolar. Are those linked, or is that a myth?
Yeah, so that's one we hear quite a bit. So people might come to us concerned, like, I just, I had this up and down mood and I'm worried I might have bipolar disorder. Or we do hear a lot, say in media or movies or TV shows or just in general conversation, people will say like, oh, I'm really bipolar today, or, my bipolar is acting up. And, if you say, well, do you have the diagnosis? I mean, that's, a serious diagnosis. They'll say, no, I just, going through some mood swings. And definitely not the same thing. So bipolar disorder is, characterized by very extreme mood swings, very, very manic behavior, and very, very depressed behavior. And it's relatively rare. And so, I would say, unless someone's been diagnosed by a professional as having bipolar disorder, kind of getting away from using that term to describe just basically mood swings. If mood up and down moods are concerning to somebody, most definitely talk to a professional, but very rarely is a mood swing actually bipolar disorder.
And I would add to that too, if you're talking about like a mood swing that you're having, in the course of your day, like in the morning you come in and you're very positive and upbeat, and then something happens and you kind of fly off the rail and you're really frustrated, and then later that day you're just kind of calm or neutral again, like that would not be characteristic of bipolar disorder. And mood swings throughout the day could be related to like a number of factors. It could be related to just your who you are as a person, your characteristic, how much sleep you got, like what you've been eating lately, stress, like other factors in your life. So it's much more likely to be accounted for by those things than a clinical diagnosis of bipolar disorder.
Okay, and this one I think isn't a myth, but actually a fact, but can suicide be preventable?
May I?
Yes, please take it away.
So this is another sort of near and dear to my heart topic. Because suicide is such a complex issue. It's very layered, and the brief answer is yes. I believe it can be prevented. Absolutely. We know that there are certain factors that help protect against death by suicide. So, connection with other people being one of the main things. So being able to connect to even one other person can help prevent suicide. Reaching out, getting help, there's a lot of factors, and be happy to follow up with some links on some resources that sort of back that up. At the end of the day, I always want to also mention that, if you know someone and they are really hurting and you offer them support and you offer them, professional help and resources, and that person does take their life, it is not your fault that you didn't prevent it. And I think that's really important for people to understand is, yes, we encourage people to offer support and give resources, but it's also very important that people don't feel that they are responsible ultimately for someone's decision.
Yeah. Thank you for adding that. I think that's important, and that's not something we always kind of touch on, so I think it's important to bring that into the conversation as well.
Okay, so I'm going back to the private messages, and I've got a question regarding schizophrenia and multiple personality disorder. The person has heard that they are the same thing. I'm going to guess this is a myth, but I'll let you guys tackle it.
Yes. Those are certainly two different clinical diagnoses. Multiple personality disorder is an outdated name for something that we know called dissociative identity disorder, or DID. So they're coming, what we call, their etiology is different, so that means how it forms or what it kind of comes from. And the symptoms are also very different, although I can imagine, you might think that if somebody is switching kind of characteristics or personality, so to speak, that might seem like schizophrenia, but schizophrenia is its own mental health disorder, and they're different. They come from different things. There's different causes and different factors at play when we're talking about those two things. What would you add to that?
Yeah, they are definitely very, very different. And I think, again, this is just, of course, you and I, we've studied this, this is our wheelhouse, but in general, people tend to lump mental health issues sort of in broad categories. And so if someone experiences psychosis or there seems to be this personality shift, we kind of lump people into the schizophrenia category, or we lump them into, multiple personality disorder or dissociative identity disorder. One of the big things is that schizophrenia is, in the grand scheme of things, much more common. Dissociative identity disorder is very rare, and there's some, contention within our own field of, what this looks like, right? So definitely two different things. But understandable that people might consider them the same.
Sure.
Okay, thank you for that. I have another question from the inbox. This person is worried about their mental health, but they don't want to take medication because they're worried about it changing their personality. Is medication changing someone's personality, fact or fiction?
That would be a myth, I would kind of say in broad terms. So generally, when we're talking about pharmaceuticals, medications, the purpose is not to change who you are fundamentally or who you are as a person. I understand why somebody might feel that way or be even concerned about that. And I think if you are talking with your doctor or they're recommending medications, it's a great conversation piece to have with your provider to share that concern, because, the whole point of taking medication, if you're feeling depressed, is to help you to feel better about who you are inside as a person and being able to kind of live your life to its fullest. So I definitely would want people to make sure they understood that. I think when we're talking about medications, we're really talking about alterations in like mood and what we call things like vegetative symptoms. So if you're feeling like you can't get out of bed in the morning and you can't get going and you're isolating yourself, those are all things that hopefully, if you are taking medication, that's the goal of your treatment. Not to kind of change who you are fundamentally. Yeah,
no, it is a myth that I hear a lot, and a lot of counseling that I do with patients is sort of around that, because there is this fear, how is this medication going to affect me? I like to say to people, particularly with severe depression or severe anxiety, that the medications we tend to look at for that, they don't change who you are, they let you be who you are, so particularly with depression, you kind of have this fog and everything seems impossible. Getting out of bed is impossible, cooking a meal, taking a shower. So the medication, allows that fog to kind of clear a bit, and who you are comes through. Depression sort of puts up this wall, right, of, okay, you can't do the things you normally do. So, that being said, I also tell people, the goal is not to take away your emotions, like particularly with anxiety or something like that, where, occasionally there might be a side effect where we see, it's called blunted affect, or people feel like numb. And what I'll tell people is, like, if that is what you feel, talk to your doctor, because the goal is not to make you feel numb. It's, again, to be able to bring forth who you are. So let's do something different.
Right. Yeah. And, medications, the purpose is not to, like, take away normal, healthy feelings. Like, normal healthy feelings around losing a loved one, normal healthy feelings about the stressors that you have in your life. Though it might be normal to feel the way you're feeling, and that the goal is not to take away like a normal human experience by any means.
It's not a happy pill. I hear that one a lot. If I take this, will I be happy? No. Again, using depression as an example, the medications that might be prescribed, again, they are sort of trying to bring you back up to, what we call baseline, what feels like more like your normal, so that you can do the things that you normally would do. But these things take, sometimes 4 to 6 weeks to work. You don't take it and automatically feel just amazing. There are drugs that do that, but they're not legal. So, I think it's important for people to understand that, it's not a quick fix, and, it's not necessarily the first thing that we might go to for somebody.
Yeah.
It's for really, depression is an illness, anxiety is an illness. The medication is to treat that.
Perfect. Well, we have another question from Teresa. She says, do children fake mental health conditions when they really want attention?
That's a great question. I mean, I would say in the vast majority of cases, I don't think anybody would fake their own distress. I think usually in a lot of cases, I'll give you an example. So kids will say that they have a stomach ache and they don't want to go to school. Well, a lot of the times they genuinely do have a stomach ache because they're anxious about going to school. So those symptoms can be really real. It could also be that they're saying that they're sick because they don't want to go to school. And sure, maybe they're not, like, they don't have a fever and they're not vomiting, but there is something underlying that around, like, there's some kind of a discomfort around wanting to avoid that situation. And they might be using language to try to verbalize that in a way that, could come out maybe misunderstood or misinterpreted, but certainly there could be something underlying that. So I don't think in the majority of cases kids are like lying on purpose, but I think there's usually some kind of underlying distress going on that's like accounting for that. Yeah.
Okay. The next question from the inbox is, substance use disorders only continue because a person doesn't want to get better. If they want to stop, they can try harder and they'll be able to. Fact or fiction?
Fiction.
Yeah.
So, this is really a contested thing, and I think it's because there's sort of old school and new school battling each other a little bit still, and some residual old school of, substance use disorders are about lack of willpower. So, years ago we used to treat someone by, literally some treatments were putting that person in the middle of a room full of other people who are in recovery and tell all of your faults, just like hammering you with this stuff, and that is, and we know now that is not how we help someone get better. So we can actually look at a brain of someone who has a substance use disorder, and we can see the mechanisms of how their brain is different than someone who doesn't have a substance use disorder. So again, same thing with depression or anxiety. If it were a matter of will, the addiction stops being fun about 6 months into it, and then people are trying to maintain in order to feel normal. So the idea that, I don't want to stop because I'm just having too much fun, that's a pretty rare reason for people to continue, when they are at that point of having a disorder.
Yeah. So without getting kind of too deep into things, like what Brittany is kind of highlighting is that there's really changes in the brain that happen that are making it so that you need more of the chemical substance to get the same effect, and then it becomes that your body is really just needing that amount, and you're not even getting the effect of the medication the substance in the way that you used to get the effect of the substance. So oftentimes people, they don't feel buzzed or drunk, but if you took their blood, they would certainly have a high ratio of alcohol in their blood. So I think that just speaks to the fact that it's not like an enjoyable experience that people are having with this. It's something that they're living with and kind of battling.
Okay, so we're getting kind of close on time, so I'm just going to offer it up to both of you. Are there any final myths you want to bust before we conclude here today?
Well, Brittany, we were talking a little bit about online tests for mental, either like, on the internet there's all these tests about like what IQ are you, or what personality do you have? Like there's like these personality tests online, or tests about, or even questionnaires about mental health. And there's a lot of information that floats around out there. And on one hand, I think that's so cool that people are interested in the brain and interested in how we as humans behave and how we think. And with that being said, there's really no support or validity for the vast majority of the things that you're going to find online, whether it be, we talked about what type of frog are you?
Or what kind of hat would that frog wear?
Yes. Or, if you got a genius level IQ, all those kinds of things that you're going to come across online are probably going to have like nothing to do with what we really know about brain science and the way we think. So just take all that with a grain of salt. But if you're having fun with it, that's all.
Have fun with it. But yeah, grain of salt. I wouldn't put it on a resume that you are a rainforest toad who likes top hats.
Yeah.
Perfect. And I actually got one more question from ZZ. He asks, does use of screen devices and or social media contribute to depression or anxiety?
That's a huge topic right now. I get asked that a lot. So I am going to go in the middle and say it's not a myth, and we're not quite sure. So it's probably somewhere in the gray area. What we are seeing is that the trend line of depression and anxiety, primarily among youth, and the kind of proliferation of handheld devices and media, they follow one another. So around 2011, 2012, that's when we really started to see a big kind of spike in those things. And so a lot of research is being done right now on that very thing. And there's just been some interesting findings around that. So while we can't say anything conclusively at this time, it does look like it's worth understanding better because there might be a connection there.
Yeah, absolutely. There's no, definitive evidence yet, either for or against that. I can say I do agree with sort of the shift in culture of constantly being on a device, constantly needing reinforcement from, social media. We see kiddos who are staying up super late on their phones, which, lack of sleep can contribute to some of these issues. And then going back to that, how connection, like face-to-face human connection is a protective factor against depression, anxiety, suicide at the extreme. And while we are able to sort of connect more than we ever have, we are missing that sort of actual human connection. So I think that could also be a factor that contributes.
That's a good point. There's actually going to be an upcoming podcast on this very topic, so stay tuned and we'll talk about it more.
All right. So, Teresa, I'm sorry we're not able to get to your question today, but we will circle back and respond to you in the comments within the next day or so. I want to thank everyone that did tune in and submit questions, let you know that you can like our page to get notified in the future when we are going live. Thank you both for being here today. This was a very productive conversation, and we encourage you to tune in next month when we have another Ask Behavioral Health themed Facebook Live. Thank you all so much for joining us today.
Thank you.
Bye.